Hi guys, can you all see me? Can you all hear me? Hi guys, good morning, rather good afternoon. Can you all see me? Can you all hear me? Quick feedback. Hi guys, good afternoon. Right, so today's discussion would be on urology. So we'll try to cover all the questions that we have in the kidney. So आज का discussion is predominantly based upon the kidney and we'll take it up from there. ठीक है? तो यूरोलॉजी में यूजुअली जो एग्जाम में क्वेश्चंस आते हैं दे यूजुअली फ्रॉम द डेवलपमेंटल डिसऑर्डर्स ऑफ द किडनी from the nephrolithiasis and hydronephrosis and the renal cell carcinoma. So, three topics that we're going to cover in an extension and we'll try to run it as early as possible. I hope audio video everything is clear. Anything that you are not comfortable with, a quick feedback. Thumbs up to go. See on the chat box. Can we start? Refreshing the chat box also. All right. Chale. Chal. So when you talk about the kidney, we'll start with the development of the kidney. So one of the common things that they'll ask you is the development of the kidney, and then because if you understand the development, then we can talk about the congenital disorders associated with the kidney. है ना? So there are two things that we would like to take up now. Yes. One second, guys. All right, chalo. So when you talk about the development of the kidney, in the development of the kidney starts from an embryonic bud, and that embryonic bud is what we call it as the pronephros. Okay? So initially the development of the kidney will start from a bud which is called as the pronephric bud. Now take this as a representation of the pronephric bud. This is what we call it as the pronephric bud. Now, from the pronephric bud, you will see that there are multiple smaller tubules are going to arise. These are what we call it as the pronephric tubules. So, from the pronephric bud, you will see a smaller tubules are going to arise, and these are what we call it as the pronephric tubules. These are what we call it as the pronephric tubules. Now, all these pronephric tubules are going to combine together. So, they will uniform together to form a one duct, and the duct that is going to arise from here is what we call it as the pronephric duct. This is what we call it as the pronephric duct, right? So you have the pronephric bud. The pronephric bud will give rise to smaller tubules called as pronephric tubules. These pronephric tubules will combine together in order to form a pronephric duct, correct? Now, once the pronephric duct is formed, you will notice that this pronephric bud, the pronephric bud will now start to slowly disintegrate. So the disintegration will be from top to bottom. It will start disintegrating from craniocaudal extension. So slowly you will notice that this is going to get completely destroyed. Now, as it gets destroyed, it is now going to continue. So this the pronephros or this pronephric bud which is present will now elongate in order to become the mesonephros, right? So this extension of the pronephros, you have to understand that it will start disintegrating from top and reappear on bottom. And when it reappears on bottom, which is called as the mesonephric bud. This is what we call it as the mesonephric bud. This is what we call it as the mesonephric bud. Now, this mesonephric bud will also give rise to the smaller tubules, which are called as the mesonephric tubules. these mesonephric tubules will combine together to form the mesonephric duct. In a way, this mesonephric duct is actually an extension or the continuation of your pronephric duct. Now here, once the fusion is going to occur, the same thing is going to develop here. This is now what we call it as the mesonephric duct. Now this mesonephric duct is also commonly called as the Wolffian duct. And remember, the fate of the Wolffian duct depends upon the sex of the baby, that whether it is going to be male or female. Based upon that, the Wolffian duct is going to take its own course. Now you need to understand that once the mesonephric bud is formed and the mesonephric duct is formed, once the duct is formed, the same thing what has happened in pronephros, it will happen here again. You will now notice that the mesonephric bud will also disintegrate. Now as it will disintegrate, it is now going to reappear as the metanephros. It is now going to reappear as metanephros. So finally, the eventual end result is development of the metanephros. It is the metanephros, right? Now, as the metanephros is formed, you will notice that the mesonephric duct which is formed, you can see here, we have the mesonephric duct. This mesonephric duct will go and amalgamate, or I can say it will fuse with this structure which is called as the cloaca. Okay. So what is going to happen is this mesonephric duct or the Wolffian duct that is formed, it will continue to travel and it will go and attach or open into the cloaca. The minute it comes and touches the cloaca is going to get stimulated, and the stimulation of cloaca will give rise to a bud in a retrograde fashion. The minute it comes and touches, there is a bud that develops, and this is what we call it as the ureteric bud. This is what we call it as the ureteric bud. The ureteric bud is going to arise from the cloaca. Now, as the time passes, you will notice this ureteric bud will continue to grow towards the metanephros, and eventually it will go and fuse with the metanephros, resulting in collecting system. Now, what is there for us to understand? This metanephros that is formed, this metanephros is now going to proliferate, and this proliferation of metanephros will result in development of renal parenchyma. It will result in the development of the renal parenchyma. This will result in the development of renal parenchyma, right? So eventually what you look at the end, you will notice that the metanephros will develop into renal parenchyma. It will develop into renal parenchyma. Ureteric bud will result into ureter. It will develop ureters and collecting system. It will develop into ureter and collecting system. Cloaca will develop into bladder. The cloaca is going to develop into bladder, and this is how the entire kidney is going to be formed, right? So the development of the kidney started. The development of the kidney started with pronephros, that is pronephric bud. From the pronephros, it forms into mesonephros. From mesonephros, formed to metanephros. Metanephros develop into renal parenchyma. This mesonephric duct, which is called as the Wolffian duct, that Wolffian duct will go and attach to cloaca. It will stimulate the cloaca. It will develop into ureteric bud. That ureteric bud will develop into ureter, and that ureter is going to combine with the kidney to develop into renal parenchyma, right? So the whole renal system, that is your kidneys, ureters, and bladder, is developed from this particular component, right? Now, once the kidney is developed, it won't sit at its location. Now, it has to develop. Now, what is going to happen? We talk about the first phenomenon. So, this is in the development of the kidney. These are the kidneys are developed. Once the kidneys are developed, what is going to happen? Now, if you take this as a representation, of the abdomen and the pelvis. This is, let's say, the scrotum. This is the inguinal canal. Now, there are three events in the development of the kidney that is going to happen. The first event is the development of the kidney in their corresponding iliac fossa, right? So, if you look at, this is the right kidney, it will develop into right iliac fossa. This is the left kidney, it will develop into left iliac fossa. So, the first event is the development of kidney in the corresponding iliac fossa. Once the development is completed, the kidney will now be going up, that is towards its normal location. This is what we call as the ascent of the kidney. Now, as the ascent of the kidney occurs, the collecting system is going to be face up. Now the collecting system is face up. There is no pump in the kidney to push the urine out. You need the urine to drain because of the dependent status of gravity. In this context, the urine cannot be drained. अब common sense use करो कि अगर kidneys अपने corresponding iliac fossas में develop हुए, उसके बाद किडनी की एसेंट होगी, लेकिन कलेक्टिंग सिस्टम फेस अप है. अगर कलेक्टिंग सिस्टम फेस अप है तो यूरिन ऐसे उछल के थोड़ा ना गिरेगा, है ना. तो इट वोंट बी एबल टू ड्रेन आउट. तो पूरा यूरिन वापस पूल करने लगेगा किडनी में. तो किडनी बोलती है ये तो प्रॉब्लम हो जाएगा. अगर पूरा यूरिन ऐसे पूल करने लगेगा, इट विल रिजल्ट इन हाइड्रोनेफ्रोसिस, किडनी स्वेल अप हो जाएगी, स्टोन्स फॉर्मेशन हो जाएंगे, किडनी का डैमेज होगा. बॉडी बोलती है आई विल नॉट लेट दिस हैपन. सो हाउ विल इट डस? सो ये जो फेस अप किडनी उसको बोलते हैं हम फेस डाउन कर देंगे. इतनी सी प्रॉब्लम है, ठीक है. सो द नेक्स्ट ओरिएंटेशन is going to align the kidney so that the collecting system is going to be face down. So the last event is going to be alignment, right? So if you look at this, there are three basic events which has occurred in the development of the kidney, right? So the first event is the development of kidney. It is the development of the kidney in its corresponding iliac fossa. So the first thing that you notice is the development of the kidney. It is the development of the kidney in its corresponding iliac fossa. ठीक है? Now, once it is done, the second event is the ascent of the kidney. It is the ascent of the kidney. The kidney is going to rise to its normal status. And the third event is the alignment of the kidney. It is the alignment of the kidney, right? So kidney is going to rotate and become to its normal aligning factor. So this is how the kidneys are developed. They're going to develop in the corresponding iliac fossas. From there, they are going to ascend. From there, they're going to rotate and align, and hence the development of the kidney is going to be complete. So when you look at the cross section of the kidney, once the kidneys are developed, so this happens to be the developmental component. We call this is the developmental component of the kidney. Now, once the kidneys are developed in their corresponding iliac fossas, now you will see that what is the renal anatomy, right? So we'll just place it here only. So talk about the renal anatomy. We'll talk about the kidneys anatomy. Now, when you look at the renal anatomy, just for the sake of understanding, let's quickly look across here. Now, this is how the renal parenchyma would look like, right? This happens to be your pelvic-calyceal system. This will develop into major calyxes. This will bifurcate into minor calyxes, right? There are around 2 to 3 major calyxes, and there are 2 to 3 minor calyxes per major calyx, right? Immediately, you will see surrounding this calyx is what we call it as the inner cortex and the outer medulla. I can say the inner medulla which is present. This is the medulla of the kidney and the outer cortex. We call it the middle medulla and the outer cortex. M for middle, M for medulla, and the outer cortex is present, right? Now, if I just label it, this will understand better for us. So this is your pelvic-calyceal system. This is your pelvic-calyceal system. You have, this is your major calyx. These are what we call it as the minor calyx. This is what we call it as the minor calyx, right? Then you will notice that there is middle medulla. This is the middle medulla of the kidney. And then you have the outer cortex. This is the outer cortex of the kidney. So you have the middle medulla and the outer cortex of the kidney. Now, until this point, everybody is like nothing spectacular about it. Now, from here onwards, you will notice that there is a pad of fat that is going to be available. That is what we call it as the perinephric fat. This is what we call it as the perinephric fat. This is what we call it as the perinephric fat. Surrounding the perinephric fat, there are two renal fascias. One is on the anterior surface, another on the posterior surface. So we have the anterior renal fascia, and then you have the posterior renal fascia. Then you have the posterior renal fascia. And surrounding this, there is another pad of fat, and this is what we call it as the paranephric fat. This is what we call it as the paranephric fat. This is what we call as the paranephric fat, right? So if I just label them as well. So when you look at this is your perinephric fat. Perinephric fat is the fat which is immediately next to the kidney, which is here. After that, you have anterior renal fascia. You have the anterior renal fascia. Now, this anterior renal fascia is also called as, or commonly referred to as, the Gerota's fascia. Also commonly known as the Gerota's fascia. This is a Gerota's fascia. Then you have the posterior renal fascia. This is the posterior renal fascia. This posterior renal fascia is also called as a Zucker-Candles fascia. This is your Zucker-Candles fascia. And the last one that you have is your paranephric fat. This is what we call it as the paranephric pad of fat. This is what we call as a paranephric pad of fat, right? Now, this is very important because every single time you write an answer, they would want you to give you the basic objective of the kidney, of how it looks, what it looks and all. So this is right in front of us. I hope everybody is quite clear. So we have the middle medulla. The green one that I'm sharing is the outer cortex. Surrounding the cortex, you have the perinephric fat. Then you have the Gerota's fascia. Then you have the Zucker-Candles fascia. Then you have the paranephric fat. Then you will notice that at this particular junction, you have the uretus. So this is the ureter that is present, right? Now the junction where the ureter and the pelvic calcium system, the pelvic calcium system is also called as PCS. PCS is your pelvic calcium system. The junction where the ureter, so this is your ureter. The junction where the ureter and the pelvic calcium systems are meeting, this we called as PUJ, that is a pelvi-ureteric junction. This is what we call it as a pelvi-ureteric junction. This is what we call it as a pelvi-ureteric junction, right? So this is with respect to the renal anatomy that you should be aware of, right? Everybody is clear? तो ये basic है. So we learned about how the kidneys are developed in their embryonic phases, how the kidneys are going to ascend and develop, how does the kidneys basically look from outside to in and inside to out. Both of them are equally important. Then the arrangement at the renal hilum. Renal hilum is also very important. The arrangement of structures at renal hilum. Now, the renal hilum is very important just for the sake of understanding. Let's say this happens to be the right kidney, and let's say this happens to be the left kidney. This is the right kidney, this is the left kidney. We all know on the left side, the aorta will be more, I would say, inclined towards the left side, and the IVC would be more on the right side. So this is where the inferior vena cava is going to be there, right? So look at this. This is the inferior vena cava. This happens to be the aorta. Now, obviously, the renal artery, renal vein, everything is going to be there. So the first structure that you will see is going to be the renal vein. You will see from here, this is going to be the right renal vein, and this is going to be the left renal vein. So needless to tell you that the left renal vein is far more longer in length when compared to the right one. Then you have the renal artery. The renal artery is going to go here. This is the right renal artery and this is the left renal artery. So you would notice that the left renal artery is shorter. Then you see the pelvic calcium system. So from here you would see the renal pelvis is going to come and this is the ureters that are going to go across here. So the pelvic calcium system is going to be the lowermost structure that you will see, right? So when you look at the arrangement at the renal hilum, if you look at the arrangement at the renal hilum, the top structure that you will see is going to be vein. After vein, there is artery, and then you have the pelvic calcium system. The mnemonic to remember the arrangement is going to be VAP, right? So on top, you have renal vein. Below the renal vein, you have the renal artery. And below the renal artery, you have the pelvic calcium system. So this is the structures in the arrangement from top to bottom. So when you say the craniocaudal arrangement, from top to bottom, this is the craniocaudal arrangement. So they'll ask you, what is this arrangement? This is from head to toe. This is called as a craniocaudal arrangement. This is what we call it as a craniocaudal arrangement. This is going to be the craniocaudal arrangement. This is going to be the craniocaudal arrangement that is going to be from head to toe. This is the arrangement that you need to have. Another thing that I would like to add just for the sake of completion here, specifically in males, let's say this is the representation of the right testes. Let's say this is a representation of the right testes and this is a representation of the left testes, right? So let's say this happens to be the right testes and this is the left testes. The right testicular vein will drain directly into inferior vena cava, whereas the left testicular vein will drain into left renal vein. The left testicular vein will drain into left renal vein. This is very, very, very important because when we'll talk about in terms of varicocele, one of the reasons why varicocele will occur on the left side is if the renal tumor comes and occludes the renal vein, the blood from the testes will not be able to drain out. All the blood will start pooling inside the testes and resulting in varicocele, right? So two important points to be remembered. Number one, the left renal vein is longer. It is longer than the right renal vein. That is the first important point that you should know. Second, the right testicular vein drains into IVC, whereas the left testicular vein drains into left renal vein. So these are the important points. It is going to be important points to be remembered. Correct. The pooling of blood is more easier on the left side because of its architecture, dependency, all that. And henceforth, varicocele is more common on the left side when compared to right side. Okay, so that's the orientation that you need to have with respect to, okay, sometimes it just misbehaves. Give me a second, guys. It's just getting updated. One second, guys. Okay. So this is with respect to the anatomical orientation of the kidney and the renal part that you should be aware of, right? Now, another very important thing is they will ask you the course of the ureter and what are the different constrictions that you can have. So, ureteric constrictions. You have the ureteric constrictions. So when you talk about the ureteric constrictions, let's look at the ureteric constrictions from where on which context it is going to happen. Now you take this as a representation of the kidney. This happens to be the pelvic-calyceal system. And let's say from here you have the ureter, which is going to go. Now as this ureter opens, this is the site where it is going to open. Let's say this is the bladder that you have. Right? The area in which it is going to open into the bladder is called as the trigone or the trigonal ridge, right? So these are the various components that you can see. This is the pelvic-calyceal system that you have. These are the major and the minor calyxes, right? Now, what are the constrictions that you have? The first constriction that you can see is at the level of the pelvic-ureteric junction. This is your first constriction that you have. The second constriction is going to be at the level of the iliac bifurcation. Now, if you take this as a representation of the aorta, this is the common iliac. The common iliac will now bifurcate into internal and the external iliac, and this bifurcation is at this particular level. So the second constriction is at the level of iliac bifurcation. The third constriction depends whether you are looking at a male or a female patient. Now in male patient, there is a structure which is going to override like this, and this is what we call it as Vase difference in males. In females, it is going to be your round ligament. So third constriction is at this particular level. The fourth constriction, when it is piercing the bladder wall and becoming inside, this is called as intramural. And the last constriction is when it is going to open at the orifice, right? So altogether, there are 5 constrictions on narrowing, right? Now, what are the constrictions of the narrowing that you have? The first constriction on narrowing is at the pelvic-ureteric junction. It is at the pelvic-ureteric junction. The second is the bifurcation of the iliac vessels. Third, it is going to be for males, we call it as the Vase difference, and females, it is going to be the round ligament. Females, it is going to be round ligament. This, when it is the bladder, it is piercing the bladder when it is becoming intramural. And then if it is at the opening, and this is what we call it as a trigonal ridge, so I can say ureteric orifice, at the level of the ureteric orifice. Now these are the sites where you have the ureteric constrictions, right? So the ureteric constriction starts from the pelvic-ureteric junction, then at the iliac bifurcation, then at the Vase difference and round ligament, then when it is going to go inside the bladder, when it is becoming intramural, and the last constriction that you will see is considered to be as the ureteric orifice. Somebody is asking, constriction is narrowed. Yes, constriction are sites where the ureter is getting compressed, right? These are the sites for ureteric compression. So when I put a ureteroscope and I go inside, these are the sites I will get a natural narrowing. I don't need to worry about it. तो मुझे डरना नहीं है जब भी मैं कोई ureteroscope लेके जा रहा हूँ ना, तो ये नहीं सोचना कि यार ये constriction narrowing क्यों हो रही है, क्योंकि इन जगह पे normal constriction narrowing आपको देखने को मिलेगी, ठीक है? So that is with respect to the natural constrictions that is going to exist. Clear? So these are about the anatomical orientation. Okay. Chalo. It is not construction, but it is constriction. Now, let's do a quick recap of what we have learned. We started with the development of the kidney. We know the kidney is going to develop from the pronephric bud. From there, it goes into development of mesonephros. From there into metanephros. Metanephros eventually converts into kidneys. The mesonephric duct, which is going to go and touch the cloaca, will give rise to ureteric bud. Ureteric bud will go and combine with the metanephros to form the collecting system. The bladder is developed from the cloaca. The whole system is going to be from here. Once the kidney development is complete, they develop in their corresponding iliac fossa. From there, they go and ascend into corresponding lumbar regions. From there, they convert, they align themselves so that they can drain. And these are 3 things: development, ascent, and rotation are the 3 phenomena that are going to occur during the development. Now, when you look at from kidney from outside to inside, the outermost is going to be paranephric, then you have paranephric fat, then you have the Zucker-Candles fascia, which is posterior renal fascia, Zerotas fascia, which is an anterior renal fascia, perinephric fat, then you have cortex, then you have medulla, then you have pelvic ulcer system, then you have pelvic ureteric junction and the ureter. This is in the same sequence. याद रखना है, भूलना नहीं है, क्योंकि आपसे जब भी पूछ लेगा कि पीसीएनएल का प्रोसीजर डिस्क्राइब कर दो, वंस यू नो द एनाटॉमी, क्या करना है, पीसीएनएल में एक प्रोब लेना और घुस जाना है ना। कहां से घुसोगे आप, यहां से आना शुरू करोगे तो बोलेगा कौन कौन से लेयर्स आप पियर्स करते हो जाओगे, फ्रॉम द पैरानेफ्रिक फैट ऑल द वे टू पेल्विक अल्सर सिस्टम, यू आर गोइंग टू गो थ्रू दैट पर्टिकुलर साइट. Then they'll ask you the orientation of the renal hilum, very very important. बेटा top to bottom क्या है, craniocaudal, VAP, mnemonic है, vein, artery and pelvic ulcer system. Then you should know the left renal vein is longer than right. Common sense है क्योंकि IVC is on the right side, so kidney is on the left side, so obviously it's going to have farther distance from there. यही context है, whenever you're taking a kidney from a donor, no, we'll always prefer the left kidney because it is a longer renal vein. It allows me to get a better anastomosis, है ना, ठीक है. Obviously, the left testicular vein drains into the left renal vein. That is one of the reasons why left-sided varicoceles are more common. Ureteric constrictions, which are narrow constrictions or narrowing, which is within the ureter, are seen with respect to these particular sites. 5 sites hai. If they ask you which is the narrowest site, ureteric orifice is considered to be the narrowest site. It is the narrowest site of the ureter. This is considered to be as the narrowest site of the ureter. But a right kidney will be placed at a lower level because right side में आपका liver आ जाता है ना, तो liver won't give you that much amount of space. Left there is no problem, so left is slightly higher up. But a ureterobladder junction is what we call it as, where it is becoming intramural, है ना, तो intramural site is not that constrictive. Clear? Chalo. So this is the basic objective that you have to construct around. Now, we'll talk about the congenital disorders. We'll talk about the congenital disorders of the kidney. Now we talk about the congenital disorders of the kidney. Again, I can divide them into a very clear concept that how these disorders are going to play across. Now, I just want you to take my lead and tell me what's happening. Let's say this is the site where you have the developmental component. I told the kidneys are going to develop in their corresponding iliac fossa. This is the first event. Once the development of the kidney is done, they are going to go and to their respective sites. And once they have gone into their respective site, the last thing that is going to happen is going to align the kidneys so that they become face down, right? So this is the whole event in the development, right? When you look at the development of the kidney, this is the first event, this is the second event, this is the third event, correct? Nothing spectacular, कोई नया नहीं बताया, कुछ ज़्यादा नहीं बताया, मैंने आपको इतना बताया कि किडनी जब डेवलप होती है अपने करस्पॉन्डिंग आइलियक फोसा में डेवलप हो जाती है, वहां से फिर वो ऊपर जाती है, वहां से ऊपर जाने के बाद वो रोटेट कर जाती है, इतना ही कॉन्सेप्ट है, राइट? नाउ my question to you is, now imagine these two kidneys are very closely placed with each other, क्योंकि दोनों अपने corresponding iliac fossa में develop करें ना, iliac fossa is a very narrowed space, बहुत confined space है. Now if both the kidneys are going to be so close to each other, they can now come and touch. और जब वो छुआ-छुई हो जाती है, तो थोड़ा बहुत touch खेलने लगते हैं, तो obviously they get fused. और जब ये fuse हो जाता है, when it gets fused, what do you call this? When these two kidneys, which are developing during their embryonic development, they come very close to each other and then they come in contact and hence they fuse. What is this fusion called as? क्या बोलते हैं इसको? What is this fusion called as? Anybody? But I'll be only taking academic questions now. Whatever you want to ask, please ask after the lecture. No problem. Okay, so one of the common misconception is about कि इसको horseshoe kidney बोलते हैं. This is not, no beta, this is not called as horseshoe kidney. ठीक है? Yes, I'm coming to that. So let's talk about the first congenital disorder, that is by the name of horseshoe kidney. Just fusing the lower poles is not called as horseshoe kidney. Horseshoe kidney is a combination of two different anomalies. ठीक है? Now it is a combination of anomaly. It is a combination of anomaly of fusion. It is going to be a combination of anomaly of fusion with anomaly of ascent. With the anomaly of ascent. Now let's try to understand what is the objective behind it. We said that this is where the kidneys are going to develop, right? Now, as the kidneys are going to be placed close to each other, now because they're placed close to each other, they can come in contact, and when they come in contact, they can fuse. When they fuse, this fusion is what we call as anomaly of fusion. Now, once they fuse, they are not able to go up also. What is the prevention? So what happens is, once the fusion is going to occur, right, they are prevented from going up, because you will notice that the aorta, which is going to be traveling from here, the aorta is dead in the center, and this is where the aorta is going. Let's say there is a blood vessel that is going to originate, and it is going to go on top of this fused segment, right? You see, there is a blood vessel that is going to override this area, and this blood vessel which is overriding this fused part of the horseshoe kidney is your inferior mesenteric artery. So inferior mesenteric artery is originating like this. It is preventing the horseshoe kidney from going up. So because of anomaly of fusion and anomaly of ascent put together is what we call it as horseshoe kidney. So eventually when you look at this, this is how the horseshoe kidney is going to be presented. You will notice this is the fused segment of the horseshoe kidney. Now the part of the horseshoe kidney which is fused is what we call it as the isthmus of the horseshoe kidney. This is what we call it as the isthmus of the horseshoe kidney, and dead in the center, you have the aorta. Dead in the center, you have the aorta, and on top of the aorta, you see this is your inferior mesenteric artery. So it is the inferior mesenteric artery which is preventing its ascent. Okay? So usually when you talk about it, they just ask you the various components. This is what we call it as the isthmus of the horseshoe kidney. This is what we call it as the isthmus of horseshoe kidney. Now remember, the isthmus of horseshoe kidney is usually seen between the second and the third lumbar vertebra. It is usually seen between the second and third lumbar vertebra. This is between second and the third lumbar vertebra, right? So the isthmus is the area which is fused, and this is between the L2, L3 part, or I can say it is on the component. So basically isthmus is usually formed on the lower, I can say the most common site. The most common site for this isthmus to be formed is the lower pole of the kidney. It is the lower pole of the kidney. Remember this fusion, no? Now, this fusion can be at the lower pole, mid pole, upper pole. Most commonly, it is going to be on the lower pole. Hence, that fusion will give you that horseshoe shape basically, right? So, the overall most common site is going to be, the lower pole of the kidney. It is going to be the lower pole of the kidney, right? Now, it is because the inferior mesenteric artery, the ascent of the horseshoe kidney is prevented. It is the inferior mesenteric artery which prevents the ascent of horseshoe kidney. Right. So we all know fusion is because of closed, proximity between the two kidneys, and the ascent is prevented because of the inferior mesenteric artery. Now we have the clarity on both the components that it exists, right? Now, another very important thing, the isthmus of the horseshoe kidney, it contains functional tissue. It contains a functional renal tissue. So I cannot simply go and sacrifice it. Okay? Now, imagine it this way. Okay, fine. There's a horseshoe kidney. So what is the problem? There are two kidneys which are fused. Both the kidneys are functional. They contain a functional renal tissue. They will continue to provide and produce more amount of urine. So what is the problem? There is no problem in such, right? When there is no problem in such, how would the patient become symptomatic? क्या है सुपता? Horseshoe shaped kidney. Why it is not horseshoe shaped? It is horseshoe shaped, beta. If you look at, this is how the horseshoe kidney is looking like. अगर ये horseshoe नहीं है तो फिर क्या है? मैंने जो horseshoe देखा वो ऐसे ही दिखता है. ठीक है? चलो. Now, if you look at the symptoms, so here's the note point. Remember, 90% of the patients with Horseshoe kidney are asymptomatic. They are asymptomatic. In fact, they are asymptomatic for life. You don't need to do anything. Just give them the supportive care and they'll be fine. In fact, these patients who are asymptomatic, they're usually incidentally found. They got an pain abdomen, they got an ultrasound done, and accidentally you found there's a Horseshoe kidney. Such patients कुछ भी नहीं करना है. उस patient को बोलना भैया अपनी जिंदगी आराम से जियो. Remember a very very important note point. Horseshoe kidney, HSK's Horseshoe kidney does not have any impact on survival. Horseshoe kidney does not have any impact on survival. Horseshoe kidney does not have any impact on survival. That means a Horseshoe kidney patient is as normal as you and me. तो बिल्कुल भी माथा गर्म करने की कोशिश भी नहीं करना. Absolutely chill. ठीक है. Now, those who are 10% of the patients with Horseshoe kidney become symptomatic. Now, the reason why they become symptomatic, it is not because of Horseshoe kidney. The reason why they become symptomatic, it is due to sharp angulation. It is due to sharp angulation at the pelvi-ureteric junction. It is the sharp angulation at the pelvi-ureteric junction. So what is this sharp angulation at the pelvi-ureteric junction which is resulting in the patient to develop symptoms in Horseshoe kidney? Now, to understand this, so I'll compare the normal kidney's orientation with that of the Horseshoe kidney. So we'll try to compare the orientation of the normal kidney in response to the orientation of the Horseshoe kidney, right? Now, when you talk about the normal kidney's orientation, this is how the kidney will look like. And this is where the pelvic calcium system is going to be. And this is how the ureters are going to be placed across it. Nothing spectacular when you look at it. They are like in the same context that you have, right? I want you to observe the angle between the pelvic calcium system and the ureter. It is an obtuse angle. It's a very obtuse angle. The advantage of this angle is whenever the urine is going to flow, it will flow into ureter without any problem. It will flow into the ureter without any problem. And this is how the normal kidney's orientation is. Now, in a Horseshoe kidney, you need to understand कि Horseshoe kidney में दो kidneys ऐसे थे, दोनों face down थे, दोनों पास है, फिर lower pole दोनों ने touch किया and then they get fused. So once the lower pole is going to fuse, it is going to push the kidney up. The kidney is going to move up, and now the kidneys which are face down are now becoming face up. Again, normal kidneys ऐसी हैं, आई पास में, touch, and then fused. And when the fusion occurs, जो ऐसी थी वो सीधी हो गई है. अगर यहाँ तक है तो भी ठीक है, लेकिन अगर ये isthmus और थोड़ा stiff हो जाता है, then the kidneys are going to become face up. A face down kidney has now become face up kidney. A face down kidney has now become a face up kidney, hence causing symptoms. तो यहाँ पे क्या होगा? So you will notice that the kidneys, when they start to fuse, and this is how it is going to be formed. This is the isthmus of the Horseshoe kidney, you know. Now, you see that the pelvic calcium system is going to originate in face up manner. And the ureters which are going to come, they are going to fuse in this particular fashion. You come and fuse in this particular manner. Now look at the angle between the pelvi-ureteric junction, and this is what we call it as the sharp angulation at the pelvi-ureteric junction. This is what we call it as the sharp angulation at the pelvi-ureteric junction. This is what we call it as the sharp angulation at the pelvi-ureteric junction. Now problem kya? If there's a sharp angulation, obviously you can see by yourself, agar itna sharp angulation hai, so what is going to happen? The urine that is going to be produced, the urine which is going to be at this particular area, urine which is going to produce from this area, which is at the most dependent area, will not be able to go up. So what will happen? The urine will start pooling in the dependent area of the kidney. Now, as the urine will start pooling in the dependent area of the kidney, as the urine will start forming, as the urine will start pooling in the dependent area of the kidney, this is a urinary stasis which is going to occur. Now, we all know whenever there is stasis of urine, kya hoga? Whenever there is stasis of urine, it will result in precipitation of the stones. And that precipitation of the stones will result in recurrent ureteric colic. तो यहाँ पे हर एक नया दिन एक नया stone बनेगा. So there are stones which are formed, and these are usually the calcium oxalate stones. And these stones, all these stones which are formed, these stones are going to spill into the ureter, and they will now block the ureter, causing recurrent episodes of ureteric colic, right? So in horseshoe kidney, the patient's symptoms. So talk about symptoms in horseshoe kidney. Symptoms in horseshoe kidney. It is due to sharp angulation. It is due to sharp angulation at the pelvi-ureteric junction. It is because of the sharp angulation at the pelvi-ureteric junction. Now, this sharp angulation at the pelvi-ureteric junction will result in urinary stasis. It will result in urinary stasis at the dependent site. At the dependent site. Now, this urinary stasis will result in precipitation of nephrolithiasis. It will result in increased stone formation. And that increased stone formation will present to you with recurrent episodes of ureteric colic. With recurrent episodes of ureteric colic. They'll present you with recurrent episodes of ureteric colic, right? So this is how the patient of horseshoe kidney is going to present to you. So when we talk about what is the symptoms of horseshoe kidney, these are the patients who will present to you with recurrent episodes of ureteric colic, right? Now, once you investigate, in terms of investigation, because there is recurrent episodes of ureteric colic, I can perform the ultrasound of the abdomen with pelvis. Now, when you say ultrasound of the abdomen with pelvis, you will see medial position. You will notice as medial position of kidney. The kidney are medially placed. Now, in order to evaluate, I can also perform IVP. IVP stands for intravenous pyelogram. Now, in an IVP, what you have to do, you have to give a contrast that is going to excrete via the kidneys and the urine. So wherever the urine goes, the contrast will go, and we can map. See, normal urine cannot be mapped on X-ray, but if you put a contrast, that can be mapped on an X-ray. So hence, you will find the mapping of this. So what is going to happen when you put, you will notice that the contrast is going to flow along with this. So if this is the kidneys which are present, and let's say this is the isthmus that you have. Let's say this is the caliceal system. And let's say this is the uretus. Both these ureters are going to go and open onto the bladder. So this is the urinary bladder and this is the urethra, right? So when you give the contrast is going to go, it will excrete via the pelvic calcium system, get into the ureter. From the ureter, you see the contrast is going to fill up into the bladder, right? The contralateral side will also do the same thing and come like this. So in an X-ray, I can only see the contrast. So when you only see the contrast, it appears to be like this. It's like a flower. On the other side also, you see there is this flower. And both of them are opening into a vase, right? It looks like two flowers put in a vase. Hence, it is what we call as the flower vase appearance. So, on an IVP, what is the finding? On an IVP, the finding is flower vase appearance. This is what we call as the flower vase appearance that you see in a horseshoe kidney. Now, to conclude the diagnosis, you can do a non-contrast CT of the kidney. Now, NCCT of the kidney will tell you the positional status as well as the angle of the ureter, right? So, NCCT kidney will tell me about the placement of the kidney is present, where isthmus is present, all that component can be looked across it, right? Now, how do you manage? When you look at the management of horseshoe kidney, when you look at the management, when you look at the management of horseshoe kidney, when you look at the management of the horseshoe kidney, the first thing that we have to understand in horseshoe kidney, whether it is asymptomatic or whether it is symptomatic. Whether it is asymptomatic horseshoe kidney or whether it is a symptomatic horseshoe kidney. Now, if it's an asymptomatic horseshoe kidney, you don't need to do anything. Just leave the patient on its own. So here the answer is going to be do nothing. Right? You don't need to give any precaution. You don't need to ask him to do anything or, take any other sorts of precaution. Just leave the patient on his own. Do not try to interfere much. Now, if the patient is symptomatic, right, you will see that there is, due to presence of sharp angulation, it is sharp angulation at the pelvi-ureteric junction. Now, in order to correct the sharp angulation, you have to do pyeloplasty. We have to do a pyeloplasty. This is basically to correct the sharp angulation. This is basically to correct the sharp angulation. We are going to perform pyeloplasty. Right. Guys, we have not stopped BLS. I know you've been asking many times. We have just halted BLS so that, we had the exam season that has like all the NEET, PG, INICT, FMG and all. And then you had this prof exam Farre. Once this is done, we'll resume back our BLS for sure. So when you look at the pyeloplasty, in the pyeloplasty, what are you trying to do? See, in the pyeloplasty, your objective is, this is the renal pelvis and this happens to be the ureter. Right? So my job is to convert this angle, which is such a sharp angle, I have to convert into an obtuse angle. So what I'm going to do is, I'm going to excise the pelvis like this and the ureter like this. This is the site of excision that we're going to make it out. So once you excise it, the end result that you will see, this is the pelvis. This we have excised in this particular fashion. And the ureter I've excised in this particular fashion. Right? I've taken out this sharp angulation part and then I will slowly make an anastomosis between these two. Now, once the anastomosis is formed, the end result would be like this. Now, this acute angle which was there, now it will become an obtuse angle. Now, this obtuse angle will allow the urine to flow. Here, the urine is not able to flow because of the anti-gravity drainage. And once you are able to achieve this angle, the urine will be able to flow. Now, this is also called as the Anderson-Hynes Pyeloplasty. This is also called as the Anderson-Hynes Pyeloplasty. Also called as the Anderson-Hynes Pyeloplasty, right? So this is how you manage your patients of horseshoe kidney. Clear? So again, we had a very clear consensus of what to do, what not to do. Last point in the horseshoe kidney. Remember, horseshoe kidney does not have any impact on survival. That means the patient of horseshoe kidney is as normal as you and me, right? 90% of the horseshoe kidneys are asymptomatic. They're asymptomatic. The isthmus of the horseshoe kidney, is formed between third and the fourth lumbar vertebra. I think I've said L2, L3. It is L3, L4 beta. Just make a small correction here. The isthmus of the horseshoe kidney, yeah, it is L3, L4. It is L3, L4. The isthmus of the horseshoe kidney is between L3 and L4. Right? Isthmus of the horseshoe kidney is L3, L4. Inferior mesenteric artery prevents the ascent. It prevents the ascent. Symptoms are due to sharp angulation. Because of the sharp angulation at the pelvi-ureteric junction. IVP will give you flower vase appearance. Management of symptomatic horseshoe kidney. Management of the symptomatic horseshoe kidney. It is going to be pyeloplasty. Another one, isthmus of horseshoe kidney should never be divided. Should never be divided. Except if abdominal aortic aneurysm repair. Isthmus of horseshoe kidney should never be divided except if the abdominal aortic aneurysm repair is performed. It is performed. So this is all the important points with respect to horseshoe kidney. So if the question comes for let's say a 2-mark or 3-mark question, these are the points to be written. If they ask you to write an elaborate answer, we have already discussed it, right? So this is all in all. This is all in all with respect to horseshoe kidney. Clear? So for any doubts, quick feedback, guys. Clear? Sure. So this is in the context of horseshoe kidney. Now, so this is all in all with respect to the first congenital disorder that we spoke about, if these two are going to fuse. Now, normally we say that from one kidney, there has to be one pelvic calcium system. What if there are two pelvic calcium systems, right? If they develop, it is called as the anomaly of duplication. So another disorder that we'll talk about is anomaly of duplications. We'll talk about the anomaly of duplication. Now, when I say anomaly of duplication, in the anomaly of duplication, we normally expect, so we'll talk about how does a normal kidney looks like. It's superimposed with partial duplication. And then we'll talk about the complete duplication. So the anomaly of duplication, there are three contexts that you should know. a normal, a partial, and a complete duplication. Now, let's say this is the kidney. So the kidney's orientation is going to remain same for all of them, because in this disorder, the renal parenchyma or the kidney remains normal in all the contexts, right? Now, this is the pelvic calcium system. There's a one pelvic calcium system, and this has to be one ureter. So this is normal. So when you look at this, the pelvic calcium system and the ureter, this is normal orientation. In partial duplication, this is one pelvic calcium system. There's another pelvic calcium system, but together they open with one ureter. This is called as partial duplication, right? So there are two different pelvic calcium systems, but one ureter. In a complete duplication, you will notice that there is two different pelvic calcium system, and then there are two ureters. This is called as the anomaly of complete duplication, right? Now, when you look at this basic objective, this is the difference between the normal, partial, and the complete duplication. Normal, you can see there's one pelvic calcium system and one ureter. There is pelvic calcium system 1 is there, and the ureter is 1. This is normal. If you have pelvic calcium system number 1, pelvic calcium system number 2, but there is only one ureter, this is called as partial duplication. But if you have pelvic calcium system number 1 and ureter number 1, and then you have the pelvic calcium system number 2 and the ureter number 2. If there are two pelvic calcium systems and two different ureters, this is called as anomaly of complete duplication. To be very honest, the problem in these patients are never because of the duplications. They will never have problem because of duplication. Think normal सोच के देखो, अगर दो ureters हैं भी तो क्या problem है? ज्यादा क्या हो जाएगा? ऐसा तो नहीं कि डबल हो जाएगा यूरिन आउटपुट. नो, बिकॉज यूरिन आउटपुट डिपेंड्स अपॉन द रीनल पैरेन्काइमा. पैरेन्काइमा तो उतना ही है, तो इट इज गोइंग टू प्रोड्यूस द सेम अमाउंट ऑफ यूरिन. सो एज इट प्रोड्यूसेस द सेम अमाउंट ऑफ यूरिन, इट इज नॉट गोइंग टू कॉज एनी प्रॉब्लम एज सच. तो यूरेटस भी दो है तो क्या ही प्रॉब्लम होगा? तो इन जनरल देयर इज नो इशू विद रिस्पेक्ट टू डुप्लीकेशन. बट द एनोमली ऑफ कंप्लीट डुप्लीकेशन, anomaly of complete duplication, anomaly of complete duplication is associated with, it is associated with your ectopic ureteric orifice. It is associated with the ectopic ureteric orifice, right? So anomaly of complete duplication, it is associated. Anomaly of complete duplication is associated with ectopic ureteric orifice. ये ectopic ureteric orifice क्या है? Now, in order to understand the ectopic ureteric orifice, let's take this as a representation of the bladder. Normally, when you look at the bladder, the exact points where the ureters are going to open, these are called as a normal ureteric orifice, right? So this will be at the level of trigonal ridge that you have. This is the normal site for ureteric orifice. तो मतलब यहाँ पे आपके ureters normally open करते हैं. These are your normal sites. Now, in an ectopic ureteric orifice, in an ectopic ureteric orifice, if these are the normal ureteric orifice sites, so the opening of these ectopic ureters are either too proximal or too distal, right? If they are opening anywhere else than the normal site, these are called as the ectopic ureteric orifice. These are called as the ectopic ureteric orifice. So opening of these ureteric orifices at an abnormal location, within the bladder is what we call it as the ectopic ureteric orifice. ठीक है? This is with respect to the basic orientation of the ectopic ureteric orifice. To understand this problem of ectopic ureteric orifice, we have a rule or a law, and that is called as the Weigert-Meyer law. This is what we call it as the Weigert-Meyer law. Weigert-Meyer law is designed to explain you the essence of ectopic ureteric orifice. According to Weigert-Meyer law, it says, let's say if this is the bladder, and let's say this is the normal site of the ureteric orifice. These are normal ureteric orifices that you have. Now let's say this is the kidney where you have anomaly of complete duplication. So it says that ureter that is going to apply from or come from the upper ureter is going to be more medial and is going to be more distal in opening. And ureter that arises from the lower pole is going to be more lateral and more proximal in opening. ठीक है, तो यही आपका वेगर्ट-मेयर लॉ। वेगर्ट-मेयर लॉ बोलने की कोशिश कर रहा है कि अगर यूरेटर ऊपर से आएगा तो वो थोड़ा मीडियल रहेगा, राइट? If you look at the normal orientation, this is the normal orientation of the ureter. When compared to normal orientation, आपका जो upper pole का ureter है वो ज्यादा medial और more distal opening होगा. Lateral से जो arise करेगा, I mean inferior pole से जो arise करेगा वो बहुत lateral और proximal in opening होगा, right? So according to Weigert-Meyer law, it says ureter arising from upper pole. This is ureter arising from upper pole. Ureter arising from upper pole, it is going to be medial and distal in opening. This is going to be medial and distal in opening. On the other hand, one that is arising from the lower pole. So here ureter arising from lower pole. Ureter arising from lower pole, it is going to be lateral and proximal in opening. Okay. So the problem according to Weigert-Meyer law is only this much, that one that is arising from the upper pole will be more medial and more distal in opening. One that is arising from the lower pole is going to be more lateral and is going to be more proximal in opening. Okay. Itna hi difference hai. Now, in order to understand the problem, what will be the clinical presentation with respect to complete duplication? So clinical features of ectopic ureteric orifice. We'll talk about the clinical features of the ectopic ureteric orifice. So when you say the clinical features of the ectopic ureteric orifice, it is going to vary between a male child and a female child. This is going to vary between a male and a female child. Now, why it is going to vary between a male and a female child? Because the urethra in male and females are going to be different, right? So when you look at the male child, you will notice if this is the bladder, if this is going to be the bladder, this is going to be the urethra and is approximately 25 centimeters in length, right? At the neck, you have the prostate gland, which is present here. And below this, you have the external ureteric sphincters. The external ureteric sphincters in males are in the membranous urethra. We'll talk about urethra, you'll understand these parts. In female patients, you take this as a representation of the bladder and this is the urethra that is present. There is no prostate gland and the external ureteric sphincters. EUS stands for external ureteric sphincters. The external ureteric sphincters in female, they are present at the neck of the bladder, right at the neck of the bladder, right? Now, in an ectopic ureteric orifice, what is the problem? In an ectopic ureteric orifice, I have one ureter which is crossing and opening two distal, another ureter which is opening two proximal. Same thing will going to apply in females also. One ureter that is going to go and open two distally. Now, when it opens two distally in females, it is going to cross the external ureteric sphincter. In female, the proximal opening will be proximal here, right? Now, this is the arrangement that you can see. Now, what is the problem? See, in the males, you can see that the distal opening will never cross the external ureteric sphincter. So, these patients will never have incontinence. So, these are the babies who are going to present to you with recurrent. They present to you with recurrent episodes of UTI. So, there are babies who are going to recurrent episodes of UTI. Along with UTI, every time the bladder contracts, the proximal opening which is present here will not be able to close, because see, the ureter has to go through the bladder wall, and once the bladder wall constricts, it compresses the ureters, right? And hence the ureters become closed. Here the ureteric opening is too proximal, so when the bladder wall contracts, it is not having enough amount of length of ureter to get compressed, so this opening remains open. So what is going to happen during the contraction? As the force in the bladder will eject, it will push the urine in downwards manner, but because it will also have the pressure here, it will now allow the urine to eject backwards, right? Because this is still remain patent. So when bladder contracts, some amount of urine will reflux back into the ureter, and this refluxing back into the ureter is what we call it as VUR, which is your vesico-ureteric reflux. Now imagine a patient who's having repeated episodes of UTI, and that bacteria has been pushed back into the kidney, will result in renal scarring. It will cause more damage injury in the patients, right? So in the male patients will have recurrent episodes of UTI with vesico-ureteric reflux is what you will see in the patients of ectopic ureteric orifice. In the female patients, you will not have recurrent episodes of UTI, because the urine will not pool. So every time the urine is going to come from here, every time the urine is going to flow from here, now there's nobody to stop, so hence there will be continuous dribbling, right? So there will be continuous dribbling of urine. So I can say there is incontinence. There is urinary incontinence is present, right? Apart from that, same thing is going to happen here also. Every time the bladder contracts, some amount of urine will reflux back into the ureter, and hence resulting in vesico-ureteric reflux. So there will be VUR also. This is vesico-ureteric reflux. There will be vesico-ureteric reflux as well. Why UTI beta? The concept is very simple. Because when the urine is going to pool in the ureter, the proximity of the urine in the external environment, because urine was stored in the bladder, it was detached from the urethra. Now the urine will start pooling in the urethra, and urethra has a very close access to the external environment, so it is now more prone, because there is more stasis of urine in the urethra, hence causing more prone for them to get infected, hence resulting in vesico-ureteric reflux as well as recurrent episodes of UTI. Okay? Now, in order to evaluate to look for ectopic ureteric orifice in terms of investigations, here you can perform an intravenous pyelogram. IVP can tell you about duplication. You can also perform cystoscopy to look for ectopic ureteric orifice. So once you confirm the presence of ectopic ureteric orifice, then you look at the management. Now in the management, you have to simply go with ureteric reimplantation. Reimplant the ureter to its normal site, right? It is a ureteric reimplantation should be performed. ठीक है? That means reimplantation का मतलब क्या है कि अगर distal है, इसको वापस अपनी जगह पे वापस position करो, proximal है, इसको थोड़ा length बढ़ाओ, ठीक है? So that is called as ureteric reimplantation should be performed. In our exam, they will ask you this question. तो Weigert-Meyer Law has been a previous exam question also. आप अपने university के exam papers देख लेना. They've asked you specifically Weigert-Meyer Law for 3 marks. ठीक है? It's a Weigert-Meyer Law. So this is about the ectopic ureteric orifice. Another congenital disorder which they will ask you quite often than not is your polycystic kidney disease. Now, when you talk about the polycystic kidney disease, in the polycystic kidney disease, it's a cystic disorder of the kidney where the entire kidney's parenchyma is replaced by cystic lesions, right? Before we move down to the discussion of that, the polycystic kidney disease is basically divided into two components. One is your adult polycystic kidney disease, another is child. So we call it as the adult PKD and the child PKD. The adult polycystic kidney disease and the child polycystic kidney disease, right? So we talk about the adult and the child PKDs. When you look at the comparison between these two, the adult polycystic kidney disease, they are autosomal dominant in inheritance. These are autosomal recessive. Adult polycystic kidney disease, they are associated with chromosome number 16 and chromosome 4. Here it is associated chromosome number 6. Adult polycystic kidney disease is associated with bilateral renal damage. They are associated with bilateral renal cyst. Child will also be associated with bilateral renal cyst. Right. Another important thing is the age of presentation for adult is between second to third decade of life, and in children they're usually seen within the first decade of life. They're seen within the first decade of life, right? So these are the difference between the adult and the child polycystic kidney disease. Let it be adult or child, eventually they will land up with the cystic lesion of eventually they'll land up with the cystic lesion of the kidney. So in order to understand the basic concept, see, this is the renal parenchyma. This happens to be the pelvic calcium system. Right. You will notice this is the medulla and the cortex, right? Usually when the cyst will start to develop, it is going to develop from the cortex. So usually the cyst is going to develop from the cortex. They're initially small. Now over a period of time, as the time goes on, these cysts are going to enlarge. Now as these cysts are going to enlarge, you can see the point where the cyst is formed, that area of the parenchyma is getting damaged, but at the same time the medulla is also going to get damaged. The cortex is damaging, the medulla is damaging. In general, as the cyst continues to enlarge, it will destroy the entire kidney per se. Now as it destroys the entire kidney, there are a couple of things which are going to happen. Number one, you see that the renal parenchyma is becoming irregular in its contour. It is becoming irregular in its contour. Right? And then it will be renal damage as well. Remember, renal parenchyma per se does not have any pain receptors. It is the gyrotous fascia of the kidney which is pain sensitive. When the gyrotous fascia is going to stretch, it is going to cause pain. So we'll talk about the clinical features of polycystic kidney disease. In the clinical features of the polycystic kidney disease, these patients are going to present to you with bilateral flank mass. Now, when you palpate this mass, they will have smooth surface. They will have multiple swellings, or I can say it has a smooth surface. It will have a smooth surface. It will be firm in consistency. And because it appears like a door knob, they given a nickname. This is called as the knobby mass. So bilateral flank mass with smooth surface, firm in consistency, and knobby in appearance, and knobby mass, right? Right. Then as the cyst is going to continue to enlarge, as the cyst continues to stretch, as it becomes bigger and bigger and bigger, it is now going to stretch the gyrotous fascia. Stretching of the gyrotous fascia is now going to cause pain, and that pain is now going to translate into bilateral flank pain. So here the bilateral flank mass will now convert into bilateral flank pain as well. So there is bilateral flank mass, there is bilateral flank pain. There is bilateral flank pain as well. There is bilateral flank mass, there is bilateral flank pain. Now, as the cyst continues to enlarge, it is going to rupture. As it ruptures, it is going to bleed, and bleeding will present to you with hematuria as well. It will present to you as hematuria. More important, as the renal cyst will replace the renal parenchyma with the cystic lesion, or the cyst, it is damaging the renal parenchyma. If the renal parenchyma gets damaged, the GFR will fall. Every time the GFR will fall, what is going to happen to compensate for decrease in filtrate? You will have activation of renin-angiotensin-aldosterone system, which will cause increase in aldosterone secretion. Now, problem with aldosterone, it causes vasoconstriction, and that vasoconstriction will result in hypertension, and this is what we call it as renal hypertension. This is what we call it as renal hypertension. So, bilateral flank mass, bilateral flank pain, hematuria, renal hypertension is the initial presentation that you will see, right? Now, if patient continues to ignore, it will result in uremia, and that uremia will result in end stage. It will result in end stage renal disease. It will now convert into end stage renal disease. It's an end stage renal disease, right? So bilateral flank mass, bilateral flank pain, renal hypertension, uremia resulting in end stage renal disease is what you're going to see across here. All right. So this is in the context of polycystic kidney disease presentation. Now, another very important thing is a patient who has a polycystic kidney disease, they are associated with other congenital anomalies also. Now, this is also very important. Other congenital anomalies. Other congenital disorders associated with polycystic kidney disease. Other congenital disorders associated with polycystic kidney disease. Number one, if there is cyst in the kidney, there can be cyst in other organs also. There will be multiple cysts. The presence of multiple cysts, usually in liver, then in pancreas, and then it can be present in spleen as well. So they have multiple cysts which are developed here. Along with multiple cysts, remember they are associated with Berry's aneurysm. In fact, polycystic kidney disease will always have Berry's aneurysm. So it's always associated with Berry's aneurysm, one of the most consistent extrarenal manifestation that you will see. Along with that, they'll be associated cardiovascular abnormality. In the cardiovascular abnormality, they are associated with mitral valve prolapse. They'll be associated with mitral valve prolapse. And in GIT, they are associated with diverticulosis. They're associated diverticulosis. So other congenital abnormalities. So rather than saying with the extrarenal manifestation that you have, it is in presence of multiple cysts. Presence of multiple cysts in liver, pancreas, and spleen associated with Berry's aneurysm. It is cardiovascular abnormality, that is a mitral valve prolapse, and diverticulosis. Remember the most common cause of death. The most common cause of death in patients with polycystic kidney disease is going to be hypertensive complications. It is a hypertensive complications, right? So this is the other congenital abnormalities that you should be aware of. Clear? Chal. So this is about your polycystic kidney disease presentation and the other manifestation. So when you investigate, in terms of investigation, the first investigation that you can do is the ultrasound of abdomen and pelvis. You will see bilateral multiple renal cysts. Presence of bilateral multiple renal cysts are noticed. Second, I can perform an IVP. In an IVP, I will find there is spider leg appearance. There's presence of spider leg appearance. So when I say spider leg appearance, again, it's basic common sense to understand why there's a spider leg. This is the kidney that you have. Let's say this is the pelvic calcium system. These are the renal calyxes which are present, right? So these are the major and the minor calyxes. I'm saying multiple cysts are formed, right? Let's say these cysts are initially here. Now, as the cyst is going to enlarge, this enlarged cyst is going to compress the calyx. This enlarged cyst is going to compress the calyx. Now, as it is compressing the calyx is going to become narrower. So, you can see the calyceal passage is getting narrow. You see the calyceal passage is getting narrower. So, when I send the contrast, you will see the contrast will only be able to go through this area. And all that contrast that is gone will now pull up here. And then when you do an X-ray, this is what you see. In an X-ray, you will see that the thin and then you see at the calyx and then the contrast is going. Now this thinning of the calyx is just spider leg appearance. This thinning of calyx is what we call it as the spider leg appearance. It is called as the spider leg appearance, right? If you say investigation of choice, the investigation of choice is going to be CT urography, in which you will do a non-contrast CT of the kidney to identify presence of, here you will see bilateral multiple renal cyst. There's bilateral multiple renal cyst, right? Now, how would you like to manage? How would you like to manage, right? In terms of management, the first thing that you can do, see here the patient will also present you with flank pain, right? What are the options that you have in management? The first line, remember the first line is to control the hypertension. So start the patient on anti-hypertensive medication. So start the patient on antihypertensive drugs. One antihypertensive drugs which I will not like to give is as AC inhibitors because they are contraindicated bilateral renal disease, right? So once you started the patient on antihypertensive, the second line management depends upon what symptoms that you have. Now, if the patient presents to you with severe pain, if you remember, I told you the pain in the kidney disorder or I guess the renal disorders, they cannot be because of the renal parenchymal disorders because renal parenchyma does not have any pain receptor, so it will not cause pain if the disease is confined to renal parenchyma. Only when it is going to involve the Gerotas fascia, it is the pain sensitive layer, that is where the patient is going to experience pain, right? Now, if you look at the whole context of it, as the cyst continues to enlarge, it is stretching the Gerotas fascia. Stretching of the Gerotas fascia is what is causing the problem. Now, in order to overcome that, what will you do? You decompress the cyst. If the cyst is going to get decompressed, obviously the Gerotas fascia will also get decompressed. The stretch of the Gerotas fascia will be taken off. If the stretch on the Gerotas fascia is off, the pain will also disappear. So, in severe pain, you can advise the patient to go ahead with Rovsing surgery. We can do Rovsing surgery. Now, this Rovsing surgery is what we call it as the cyst deroofing. This is called as a cyst deroofing. This is called a cyst deroofing. You can excise the cyst. If I say what is the treatment of choice? The treatment of choice is going to be renal transplant. It is going to be renal transplant. So eventually all these patients will require renal transplant, right? So first line is antihypertensive drugs. Second line is to do a roofing surgery, that is cyst roofing, decompress the cyst, and the treatment of choice is going to be renal transplantation. It is going to be renal transplantation, right? So these are with respect to the congenital disorders of the kidney. These are with respect to the congenital disorders of the kidney. Okay? Now this is our part number 1. General surgery आज पूरा नहीं होगा बेटा. आज सिर्फ we are going to take care only until this point, that is until the congenital disorders. We'll continue with the acquired disorders, that is going to be nephrolithiasis and RCC, and rest of the urology once we have the time. There's another scheduled complete day where we'll complete the entire Farre series for general surgery. Okay? So that is it for today now. We will resume back with another session because you have another class at I think 3 o'clock. So hence there's 1 hour break, and after that you will have another 3 o'clock session. Okay? So thank you so much for joining. We will resume back again with another series of Farre. This was the congenital disorders of the kidneys that we have finished. Another 2 sessions to finish the entire urology, and then from there onwards will be general surgery. Okay? Chalo. Take care. Bye. Have fun.